Thank you. Thank you so much. So is my screen visible?
Not yet, ma'am.
Okay.
Uh,
Yeah. Is it visible now?
you stop the sharing. Share it again. Yes, ma'am, it's visible.
Sure. So, good afternoon, everyone. Firstly, thank you so much for giving us your time and being a part of our monthly workshop, which is No Thrombosis National Workshop. So, before we start, I'd like to welcome our esteemed panel for today. So, we have Dr. Surya Narayan
Yeah,
Sharma
we
as a course
can see
director.
your slides.
Yes, sir. So we have Dr. Surya Narayan Sharma with us today, who is a senior consultant neurologist and stroke specialist in Apollo Hospitals, Bangalore. Sir has done his clinical and Sir has his clinical and academic interest in infection and post-stroke spasticity and also stroke rehabilitation. Sir has been the secretary for the Karnataka Stroke Foundation, Bangalore, the secretary general for the Society of Neurosonology. Sir has also gained a second rank in DM Neurology and has 35 publications, 11 book chapters, 2 books, and 29 conferences papers to his esteemed collection, and is also a recipient of the fourth National Level Paper Presentation Awards. Sir has also been an investigator in 5 international clinical trials in DNB Neurology Guide and Examiner, QAI National Assessor for Primary and Comprehensive Stroke Care Certification. Sir has also been a founder trustee of a charitable trust working in the rural education and health. Along with that, Sir is also an author of a Kannada book on stroke and which has been awarded the best medical literature in Karnataka, along with 5 other Kannada books. We are very lucky to have you on board, sir. Looking forward to a great workshop with you as a course director.
Yeah. Good
Uh,
afternoon. At the outset,
Good afternoon.
yeah.
Yeah. Next, we have on board the Major Dr. Savit Kumar. He is also a senior consultant interventional neuroradiologist at the Apollo Hospitals, Bangalore. Sir has completed his MBBS from Kempegowda Institute of Medical Sciences, Bangalore. His MD Radiology from INHS Ashwini, Mumbai, and also he has pursued advanced training in neuroimaging and interventional neuroradiology from Sri Chitra Tirunal Institute for Medical Sciences and Technology. Sir has also Sir is also a fellow of the Royal College of Radiology and has completed his M.Med from the National University of Singapore in 2014. Sir has an experience of 5 years as a medical officer in the Indian Army after MBBS. Sir has contributed to 12 publications in national and international journals with multiple paper and poster presentations at the national and international conferences. Thank you so much, sir, for being a part of our esteemed panel today. We are very grateful to have you on board. Next, we have Dr. Kishore Ramchandra. He is a consultant neurologist at the Apollo Hospitals, Bangalore. Sir is the alumnus of the Manipal Academy of Higher Education and has completed his DNB in neurology from a prestigious institute in Bangalore with an additional training in AI in healthcare and advanced management of neurological diseases from Harvard Medical School. Sir has an experience of 5 years with core expertise in stroke care, neurosonology, and transcranial Doppler (TCD). Clinical interests include headache disorders, neuroinfections, epilepsy, and neuromuscular diseases. Sir has served as a physician in charge of a COVID hospital during the pandemic, involved in a government pilot on TCD and sickle cell diseases. Along with that, Sir has also been a part of multiple publications, paper, and poster presentations at many national and international level conferences. Thank you so much, sir. We are really grateful to have you on board. Um, with this, I would like Dr. Surya Narayan Sharma to please take the session ahead and proceed with the KT Live schedule for today. RX students, have they logged out?
Yes, ma'am.
Okay. Just a minute, give me to confirm.
Sir has joined again.
Can you hear me?
Yes, sir. Yes, sir.
Yeah, sorry, there has been some technical glitch. So
No,
basically, can I start now?
yes, sir. Yes, sir. You can start now.
Okay, so at the outset, I now thank Gennova team for the opportunity and their effort in spreading stroke knowledge across the country. This is about no thrombosis national workshop on interesting cases in acute stroke management. The globally stroke is the second leading cause of death and third in India. Every year we have around 15.5 million people who are affected from stroke. And also, if you see, more than 5.5 people are dying because of acute stroke every year. If you see the morbidity, more than 100 million people are affected with stroke related disability worldwide. So this is a big number actually. Why it is happening? Because we have, coming to the Indian scenario, we have more than 315 million hypertensives. 1 in 3 adult is hypertensive. We have almost 11 crore diabetics and more than 13 crore pre-diabetics. So it's a big population. Being hypertension, diabetes, cardiac disease being one of the commonest risk factor of a stroke, we expect that this trend is going to increase. So last 15 to 20 years, there has been a major change in the way in which we treat acute stroke patients. So definitely there has been a paradigm shift because of the research, because of the trials, because of the publications and hard work from the stroke physicians across the country. So what we are, in this workshop series, what we are planning to do is we highlight one case every year, every session, and we try to, take or run through the session, and we try to give some, teaching points and some guideline based management and evidence based management. So we have Dr. Savit Kumar is yet to join. He is our interventional neuroradiologist. We have Dr. Kishore. Dr. Kishore is our associate consultant in Department of Neurology. He is a young dynamic neurologist with us. So probably we managed this, uh, 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 hundreds of acute stroke patients together as a team for last 2 years. Dr. Savit Kumar is here. He is our, as I was explaining, he is our senior consultant interventional neuroradiologist in the hospital with experience of almost 250 mechanical thrombectomies in last 5 years. And today, what we are going to do, Kishore is going to present his case, and he will give the inputs. And in between, we will take the questions and we will explain and some components about evidence based management and other things. So over to Dr. Kishore.
Good afternoon, everyone. At the outset, I would like to thank the team for letting me present this case.
Still, yeah, share. Okay. Yeah. Can you see the slides? Kalpita ji, can you see the slides?
Yes, sir. Yes, sir. The slides are visible. And you're also audible perfectly.
Got it.
Okay. So good afternoon. I'll be presenting a case which we come across in our setting, where it was an unusual cause of acute stroke in an elderly man. So yeah. So he was an 80-year-old man who was a right-handed person. So he was known diabetic. Present to her hospital at the emergency room with a sudden onset of giddiness and a loss of consciousness, which was lasting for almost 1 to 2 minutes. 1 hour later, he was found to have speech difficulty and confusional state. So there were no history of any involuntary jerky movements or tongue bite. On examination, we found BP was 140/80, pulse was 78 per minute, and it was regular, and GRBS of 140. So on neurological examination, he had expressive aphasia, difficulty in bringing out words, and his power was 5/5 and no facial weakness found. So on presentation, we did a MRI as a stroke protocol because he presented within 1 hour. So there was a hyperacute infarct in the left insular cortex, the right with a diffusion flare mismatch. So there was no signals in the left ICA atrium. And further, so you can see here the left ICA is cortex like infarct, hyperacute stroke, diffusion restriction. So through that, like it was 1 hour duration of window period. So we went ahead and like did that IV thrombolysis. So the patient was in window period. So he was thrombolized with injection tenecteplase 0.25 mg per kg, and within some time, 20 minutes of thrombolysis, patient improved. That is, speech improved. But after 1 hour, we found that he's having sudden onset occipital headache. So this was a dreaded complication in every neurologist who were thrombolizing. And suddenly we thought it could be a bleed. So CT brain was done and no evidence was bleed in that. So what I would like to highlight is in this time of stroke, time is very important. Whenever we talk about stroke, we always talk about time is brain. So every second counts, and every second we lose around 32,000 neurons, and per hour almost 120 millions of neurons. Okay, so the more we delay, the core will expand, and then finally it can go and damage more tissues. So earlier days, IV thrombolysis, what used to happen was 1995 and before, they started using urokinase, where it was very difficult at that time because always a complication was associated with that because unacceptable hemorrhagic rates were high, and it was largely treated with conservative management only. And over the time, in the 30 years, we have seen from 1995, so multiple trials have given a pathway to us for the whatever we have achieved till now. The landmark trials gave us an opportunity to treat the acute stroke patients. So NINS trial was the one which gave a gateway for the thrombolysis. That was in 1995. So it gave we in the trial they used alteplase within less than 3 hours of time. And then the next trial which gave us a pathway for 4.5 hours was ECAS-3 trial, that was in 2008. And subsequently with that, there was image selection criteria and advanced image selections in aspects as well as CT angiogram and as well as perfusion studies, which made patient selection very important for us to thrombolize the patient as well as going further for the endovascular therapy treatments. And then came the treatment option was wake up stroke and perfusion based thrombolysis. That was the time where even the patient who was presented after 4.5 hours, we can even treat the patient and give an endovascular therapy for this patient by doing a simple MRI brain diffusion as well as a mismatch study and as also a perfusion scan for this patient. And also in further ways, we came across bridging therapies with thrombectomies, with thrombolysis as well as mechanical thrombectomy. And now is the era where tenecteplase is leading the thrombolysis because of it is a single dose and it has a better recanalization compared to alteplase. So these were the evolution what I was talking about, NINS trial and then ECAS-3 at 1998, which at 2015 onwards was there was a game changer because the trials which came was more than 4.5 to 24 hours treatment for the stroke in endovascular as well as thrombectomy and IV thrombolysis. So Mr. Clean, Escape and Extend trial and SWIFT trials were 2015 onwards. They dramatically changed the treatment of stroke treatment. So this was how we used to treat the patients with starting of 3 hours and then we extended to 4.5 hours by ECAS. Then there was an extend trial. We started giving thrombolysis for 4.5 to 9 hours. There was a wake up trial, that wake up stroke trial, where we used mismatch of diffusion and flare, and there was next dawn and diffuse criteria for the mechanical thrombectomy. So completely we can treat a patient who arrives at the emergency within 24 hours time. We can give some treatment and then we can also do mechanical thrombectomy or endovascular therapies in these patients and then achieve some better outcomes. So the window period for therapeutic stroke window was 4.5 hours. It's a standard window, which always I've already explained to you about that. So any patient who is having an ischemic stroke, diagnosed with ischemic stroke, no CT or MRI doesn't show any bleed, and if there is any disabling deficit with his NHS score of more than 6, and patient can be given tenecteplase or altiplase at the dose of 0.25 or 0.9 mg per kg. The extended window was to 4.5 to 24 hours, where the ischemic stroke was diagnosed, and then there is an disabling deficits of more than 6. And any patient who is having a perfusion scan showing that core volume of less than 70 and ratio of 1.2, core and the core volume and the ischemic area, then we can take these patients for either endovascular therapy or even give a trial of thrombolysis for this patient also. So this is selection of the patient with intravenous thrombolytic therapy up to for like less than 4.5 hours. It is a standard therapy where we do a CT drain and then find out if the patient is not having any bleed. Then directly we assess by getting an NHS score. If it is more than 6, then definitely go ahead and give the thrombolysis. Or even patients can be included if they're having disabling stroke, even if the NHS is less than 6 also. And we'll be talking about that later. And if the patient is falling in between 4.5 to 24 hours window period of time, suppose the patient has woken up and just visited the ER with a disabling stroke. So what we do is we do MRI with the diffusion and the flare mismatch. If we find, then also we can consider doing a perfusion imaging and then finding out what is the salvageable amount of tissue which is left. So through this, we can actually achieve by giving IV TPI, even if the patient is already crossed more than 4.5 hours, probably even when they wake up and come to the ER. So we can treat this patient by doing this specialized imaging techniques. So some of the highlighted points about here exclusion criteria are, so when the patient is having hemorrhage in the head CT and persistent elevated BP, if it is more than 185 to 110, is absolute contraindication for giving the thrombolysis. The patient is having any of the patient is having hematological issues like coagulopathies, more than APTT more than 40, INR more than 1.7. So, and patient has taken directly acting oral anticoagulations. So those patients which have received within 24 hours of heparin, all these patients has to be excluded. And hypoglycemia is first to be treated before giving thrombolysis. And other histories are supposed to be taken are any ischemic stroke within 3 months or even severe head trauma, previous intracranial hemorrhage, intraaxial intracranial neoplasm, GI malignancy or even bleed within 21 days, and intracranial or intraspinal surgery within 3 months. Presentations with infective endocarditis, very important about this. Patient who are with infective endocarditis should be excluded. And any patient who is having an acute aortic arch dissection. So the concept came was here we are dealing with 0 to 4.5 hours and then the wake up stroke. So core and the penumbra concept came where we have to find whether there is a diffusion flare mismatch in this. And sometimes we see 4.5 to 9 hours of extended window. We do a perfusion scan. We find out that the core is less than 70 and the core ratio is 1.2. These patients can be taken up for the endovascular procedures. Give a thrombolysis for this patient, and then we can take them for endovascular procedures. So differences we see from while over the years we have found that altiplase was the first one we were using maximum during this stroke intervention or even thrombolysis. Over the time we have shifted over to tenecteplase. Why we have done that is because it's a single intravenous bolus. So also it is given at the dose of maximum 0.25 mg per kg, maximum dose of 20 can be given, and then half-life is a longer half-life, and then the specificity for the fibrin is higher in tenecteplase. So bleeding risk also is lower in case of tenecteplase compared to altiplase. So these are some of the highlighting points about tenecteplase. It's genetically modified tissue plasminogen activator. Higher fibrin specificity has a longer half-life, single bolus administration, and the advantages over is it's non-inferior to the altiplase, higher early recanalization in the large visual occlusion. It is preferred in many guidelines, and also it is large visual occlusion prior to the thrombectomy. Also, you can use tenecteplase, which has given a good outcomes in these patients. So coming back to our patient where we had thrombolyzed.
This is now, Dr. Kishore has nicely explained where we stand as a current guidelines for IV thrombolysis. How we started, because if you see the literature, it is in 1980s that streptokinase was used in line with myocardial infarction treatment. So every patient in whom streptokinase was given, they had bled. So the study was prematurely closed. So then 1995 was a game changer, but there were a lot of riders, only 3 hours window period, lack of availability, lack of awareness, and all. So after 2015, there has been a major change in the way in which we manage acute ischemic strokes, both from IV thrombolysis as well as mechanical thrombectomy. This patient had a acute onset focal neurological deficit, and he had a left MCA infarct within window period. Thrombolysis we started, NHS was low NHS, thrombolysis was given. Then he worsened 2 hours post thrombolysis. Now, Dr. Kishore is going to, take you through the next part, wherein, what happened to this patient and what we did later. Over
Yes.
to Kishore.
Thank you, sir. So 2 hours post thrombolysis. So the patient had a clinical worsening in this situation where he had developed right hemiparesis with global aphasia. Initially, he had only a speech difficulty and then found out to have NHS of 13 now. So power was almost 0/5, and then speech was completely absent in this patient. And at the presentation, what we see here in the MRI, there was only insular cortex hyperacute infarct was there. Gradually, after 2 hours, we see that new infarcts have been developed in the insular cortex as well as in the upper sections here, in the parietal cortex as well as the frontal cortex here. So probably the patient has worsened because initial MRI to the next MRI, there is a progression, and then there is interval increase in the infarct size. So we suspected this probably like the patient was worsened, and then also the NHS was more than 12 to 13 now. So we planned for mechanical thrombectomy and rescue sending of ICA, because initially ICA was not seen in the first MRI when we did MRI angiogram there. So yeah, what happened here is the patient is having more than 6 of NHS score within 24 hours of window period of time, and then stroke due to anterior circulation, large vessel occlusion. There is an aspect score that it is probably coming up to 6 in this patient, and the patient is also like he'll be like he is candidate for the mechanical thrombectomy in this patient because aspect score is good, as well as it's an anterior circulation and NHS is high. So the first thing what we are thinking is to do the endovascular procedure for this patient. And
So we will. So we have Dr. Savit Kumar, who is the interventional neuroradiologist who attended this patient. So before going to this particular case, I would like to know what are the basic things you consider when you take a patient for mechanical thrombectomy. That is number one. And number two, what are the basic steps? Like I want, there are a lot of young doctors, young neurologists, DNB students, DM students who are watching this. For their benefit, I request you to, highlight how you, take a patient and what are the things you look at from interventionist perspective, do's and don'ts, and then probably we'll go to this case. Over to Dr.
So the primary thing before doing a mechanical thrombectomy is to choosing a patient. So the most important thing is to choose the right patient. So there are so many guidelines which has been set up for us to help us choose the right patient. First, coming to the clinical symptoms. So patient should have an NHS score of at least 7 or more to be to become a candidate for mechanical thrombectomy. So that clinically the patient has a moderate stroke. So any NHS score less than that, then we have to choose the case based on case-based selection. So ideal is an NHS score of 7 or more. That is with the clinical criteria. Then coming to the imaging. Imaging, patient should have a large vessel occlusion. So when we say large vessel occlusion, there should be an occlusion of the ICA, the proximal MCA, vertebral artery or basal artery. Any of these large vessels should be occluded, and patient should have a small infarct. Now, when we have a scoring for the infarct, the scoring is called as an aspect scoring. So based on this scoring, the higher the number, smaller is the infarct. So it is scored out of 10. So any score of 7 or more is an ideal candidate for mechanical thrombectomy. So we have a clinical criteria, we have a imaging criteria. Now, once the patient fits into both these criteria, patient can be taken up for mechanical thrombectomy. There is no other blood investigations or other evaluation required before doing a procedure. Echo, ECG, or cardiac evaluation, cardiac fitness, serum creatinine, none of these is required before taking up the patient. Now, once we have selected a patient and his for mechanical thrombectomy, a decision has to be made whether you will do it under local anesthesia or general anesthesia. There is varied literature on the benefits of each, but the studies are favoring doing the procedure under general anesthesia, both for the ease of the procedure and better patient management under anesthesia. So, patient is selected. The plan is to do the procedure under general anesthesia, and the patient is taken up for the procedure. While planning the imaging of the patient, you also plan what is the type of the arch, what is the level of occlusion, is there a tandem occlusion, that is occlusion both in the neck and in the intracranial, and whether it's a partial occlusion in the neck or it is a complete occlusion, or if you can identify whether what's the etiology, is an atherosclerotic disease which is causing an occlusion, or is it a dissection which is causing occlusion. So all these knowledge will help you to plan your intervention. Now the patient is selected, the assessment of the imaging is done, and he's intubated, and then the patient is taken up for the procedure. The access is always through the groin. Radial access also is possible, but the ease of doing a procedure is always when we do it through the groin. Now, once we get a groin access, we do an angiogram to confirm the imaging findings and assess the occlusion, and then proceed with removing the clot or thrombus from the vessel. Now, once the clot has been removed, if there is a tandem lesion, if there is an underlying dissection, underlying stent, then we have underlying atherosclerotic marrow, then we have to take a decision on do we need to tackle this dissection or atherosclerotic marrow at the sitting or on a subsequent sitting. So based on that, we may decide to do a stenting for that atherosclerotic lesion or a dissection, or manage conservatively and plan for stenting in a subsequent date.
Okay, so in this patient, what all you did, because the images are here.
So
can
the
you explain?
angiogram showed, if you look at the image on the left-hand corner of the image. So this is the initial angiogram which is obtained from the common carotid artery. We can see that there is no filling of the internal carotid artery beyond a small stump. Now here, this is where the site of occlusion in the internal carotid artery in the neck is. Now this occluded segment is crossed. So we have a catheter beyond the occluded segment, and the angiogram now shows some of the intracranial vessels, but here there's a cutoff. So this is a middle cerebral artery branch. So subsequently, our devices, which will include an aspiration catheter and a stent retriever. You can see these dot like things. So this is actually the stent retriever, which is a stent-like device which is placed in the occluded vessel, so that the thrombus gets trapped by the stent, and the once the stent is removed, the thrombus also comes out. Now, if you see, this is pre, where the vessel is seen occluded. A stent has been placed to recanalize the vessel, and if you see this post, the vessel has been opened. So this is the recanalization of the intracranial artery, and here we see the clot fragments which has been retrieved from the occluded blood vessel. Now, once the intracranial artery is recanalized, when we look at the angiogram of the neck, here we see a dissection flap. Now you see this line within the lumen, and you see this line. This is the site of dissection. So this was the source of the patient's clot. So patient had a dissection here. There's a thrombus formation here, which then migrated up and occluded this blood vessel. Now, because this was the etiology for his, we had to plan a treatment for it. So this was stented. So this is a stent which is placed in the dissected segment. As you can see, this lumen looks very hazy and with a flap inside the lumen, but here the lumen has become clean. So this is a stent which has treated the.
So probably in this case, what would have happened is this acute stroke patient was thrombolized. The clot migration would have happened from the ICA to the MCA, and that's the reason why clinical worsening is there. As the teaching goes, if the patient after thrombolysis, if there is an increase in NHSS score by 4 points, it suggests that most likely it's spontaneous intracranial hemorrhage following a symptomatic intracranial hemorrhage. So we thought initially when patient worsened, the first thing which came to our patient would have blood in the brain. So here, paradoxically, what has happened? The clot got dislodged, probably because of thrombolysis effect, and it wouldn't have totally got diluted, and it has gone and occluded the MCA, causing worsening of the stroke symptom. So as a rescue therapy, Dr. Savit and his team did the mechanical thrombectomy, and ICA dissection was there, so we had to put a stent. So in the same day, in probably 4 hours time, he underwent multiple procedures, and then the next part of the story will start. Over to Kishore.
So as Dr. Savit said, told that there was a flap, and then we found that there was a dissection, and it is being stented here. So going further, so the follow-up CT we got the next day, and it shows a reperfusion bleed. But over the next days, we found that by doing the CT scan,
Usually this can go back to
Yes.
that. So reperfusion injury is very common. So as a young neurologist or as a young resident, don't get scared about reperfusion. It's a clinical presentation of the patient which is important. Some amount of hemorrhagic transformation of infarct, like grade 1, is very common actually. It indicates that at least there is a good perfusion which is happening. Only problem is if there is a parenchymal bleed. That is the only indication where we will be very aggressive in treating. So some amount of contrast extravasation, some amount of hemorrhagic transformation is accepted in a setting wherein we do thrombolysis and mechanical thrombectomy together. Yeah.
So in this patient, we are seeing that the reperfusion injury and some of the contrast extravasation as well. And then, so what we found was while doing the scan, Dr. Savit found that there is stent kinking during this flexion and extension. So why did this happen? We are just puzzled, and we just did the complete scan and then found out that even on axial cuts, we found that there is kinking of the stent. What we can see here in the first one, the lumen you can see it's so clear here, but here it is kinking at the flexion. And the next we got to know that the styloid process was elongated in this patient. So probably something which is causing an obstruction to the ICA was this elongated styloid process. So it's very unusual in this patient at this age. Usually it is seen in the middle age, and that syndrome is called as Eagle syndrome, where patients usually have a normal styloid process is 2.5 centimeter, and if it is more than that, it can be considered as an Eagle syndrome. It will be bilateral usually. And this patient was elderly, 80 years, and this patient had this elongated styloid process. So this was a reconstructed images where you can see that elongated styloid process here, and then in between that styloid process and the retrostyloid space, the ICA is getting kinked here, and then probably this was the reason there was a repeated trauma to the ICA, and then that has caused a flap, and then finally it is gone into a dissection. It caused a stroke, and then patient was actually on the day of Independence Day, he was doing the flag hoisting, and suddenly he fell down with giddiness and loss of consciousness and had a dissection. Probably that was the reason that migration of the clot and caused that occlusion of M2. And so finally we found out through by doing mechanical thrombectomy and stenting, this patient has recovered completely now. So the etiology of the stroke was it's a large vessel occlusion, and the mechanism was the ICA dissection causing an artery to artery embolism in this patient. And probably after the stenting, the patient improved. And what was the reason for the dissection was because of the elongated styloid process causing reduced retrostyloid space. And the final diagnosis was concluded as Eagle syndrome. It was the dynamic compression of this retrostyloid space, which was causing a cervical ICA dissection in this patient. So this is an Eagle syndrome where usually it causes vascular and non-vascular symptoms. Vascular symptoms are what we have seen in stroke. It can cause some syncopes, and non-vascular is the pain. It can cause pain, orenophagias pain, and it can be referred pain to the intraorbital as well as supraorbital pain because of the lower pineal nerve involvement. So what take-home messages we are taking is IV thrombolysis has transformed the stroke completely, and we have come from a time window to a tissue window now, because advanced image has shown that not only time is important, now it is the tissue also is important because we have come to a wake-up stroke, and more of the extended trials have shown that if there is any mismatch in the imaging techniques, then we can actually thrombolyze this patient and even salvage those tissues also. It's not only at the 4.5 hours, it can be extended beyond that also. And 10-MTPase is a winner at this point because it is being majorly used and compared to altiplase now. And as well as the future is always tissue based and is now driven towards the AI assisted techniques. And we are already using AI assisted technique, that is rapid AI software. And also we have to aim at ultra early treatments, going very swift treatment and giving the quality assessment, and as well as stroke care at the at the point of care when we receive a patient in the ER. Try to reduce the door to needle time as much as possible to less than 1 hour, like 60 minutes, and even we have achieved around 30 minutes in our hospital. That was the ER team has been trained for that time. Thank you.
So that's a good case presentation by Dr. Kishore. I thank him for that. So what are the major important take homes in this patient? One is about the atypical nature of the case. 80 years and above, earlier days, it was considered as a contraindication for IV thrombolysis. If you see the guidelines, 3 to 4.5 hours, age above 80 years was a relative contraindication. Now, age is not a contraindication. The baseline MRS score, if patient is functionally independent, if patient is leading an active, healthy life, age is never a contraindication. Number one. Number two, if you don't know the time of onset of stroke, yes, either you use the wake up stroke criteria, like for 4.5 hours, the midline from the sleep to wake cycle, or you can use the MRI. You can take MRI help, or if your center is practicing CT based therapy, probably CT angio with perfusion study would help you. But most importantly, identify a patient who needs a reperfusion therapy. That's one. And second important.
Last year.
Hello. Yeah. Second important thing, in this case is BP management. Most important. Most of the residents are, rushing to do MRI or CT and thrombolyze the patient. But suppose if patient comes at the emergency, BP is like say 200 by 100. Even before shifting to MRI or CT, give a labetalol injection or give any of the nifedipine or any of this medication, and then shift the patient to CT. Then it saves a lot of time. Later, once MRI is over, then you stand, you do firefighting to control the BP and ensure that BP control is sustained for a 5 to 10 minutes before giving thrombolysis. Just because you give an injection labetalol, after 5 minutes BP comes down, then immediately you push the drug, and within 5 minutes again BP will shoot and the patient will bleed in the brain. So please ensure BP control is the key. Now, tenecteplase has, as Dr. Kishore said, is a game changer nowadays in last 5 years, because one is ease of administration, bolus therapy, even BP fluctuation. Earlier, what problem we used to face when we used to do with altiplase was it's a 1 hour infusion. 1 hour infusion, 10%, that usually altiplase 0.9 mg per kg, 10% bolus in over 5 minutes to 10 minutes, and rest in over next 50 minutes. That's what we used to practice. But in real time scenario, what happens? After 20 minutes of starting the infusion, BP will shoot. Again, you have to stop the medicine. Again, you have to control the BP. So it was labor intensive work for the clinician. Now that part is taken care, and especially when you do a drip and ship model where you do a bridging therapy. Suppose you thrombolyze a patient, then you refer to a center where mechanical thrombectomy will take place. So then you are wasting a lot of time. So to prevent that, we are actually, most of the centers, not only us, most of the centers are resorting to tenecteplase based thrombolysis therapy. And most important, what Dr. Kishore has highlighted, systems of care. The stroke care is a comprehensive stroke program. So comprehensive stroke program, even an ambulance driver is as important as a neurologist. Even a technician is as important. Lab technician is as important as a cath lab technician is as important as a neuroradiologist. So all are equal here. everyone has to perform their roles and responsibilities so that you give the best outcome to a individual patient. That's what this is the message what we want to convey through this case, discussion. So, and AI, probably now the AI is a real game changer. So rapid AI within, even if the patient is still in the CT console, you get a, in your mobile app, you will get that there is a large vessel occlusion. This is the stroke volume. Then you can take immediate decision based on the image finding. So probably these are all the things which we can use to benefit a patient, because the guidelines is 1 hour, but you should do as early as possible. Earlier, you used to do PTINR, used to wait for the PTINR report, which used to take 15 to 20 minutes or sometimes even half an hour. So now, unless patient has a bleeding diathesis or patient is on, anticoagulation, you don't have to do anything. So you can directly thrombolize the patient. It is as safe as that. Earlier, we used to wait for platelet count. Now there is no reason to wait for a platelet count unless you suspect something. So clinically, if you suspect a bleeding diathesis, clinically, if the patient is on anticoagulation, then only you are going to do all this. Otherwise, you can comfortably, thrombolize most of the patients. And bleeding risk, don't get scared about the bleeding risk. Though literature says 3 to 7%, if you carefully choose and wisely control the BP, I can say that it is less than 2%. So, and the hemorrhagic transformation, what you see in a scan. So don't get worried, because if it's a mild hemorrhagic transformation without any clinical correlation, it may not, change the clinical outcome of the patient. Rather, they may be actually normal. You may see a big, hypotensive infarct, but patient power would have improved from probably 0 to 4. So these are all the practical things what all of you see. Once you start seeing more number of patients, probably you can, experience all these things. So with this, I hand over to the moderator. Are there any questions? We'll be very happy to take it. Yeah.
Yes, sir. So currently there are no questions from the audience as such. And
Okay.
I think definitely it was a very elaborative case with each step explained very nicely. And I would like to thank each and everyone on board for their time and for sharing this entire journey of how to manage stroke and how efficiently rather to manage stroke and how key interventions can be dealt of. So if you have anything to add, then please do, or else we can maybe conclude with the session.
Sure. Dr. Savit is there. I just want to ask him one question. Now, if you see all the trials, they are all CT guided, CT based trials. Now, most of the centers have MRI based protocol. So we all either do a CT based protocol or a MRI based protocol based on what we are looking at. So now I request Dr. Savit to just highlight few, practice points how to choose, or based on, your CT or MRI, how to pick up these patients.
So CT-based protocol or MR-based protocol is based on how good your workflow management is in our system. So if your workflow for a stroke patient management is very good, then MR is always best because it gives the best prognostication of the stroke, because the diffusion aspect is always the best assessment of the brain damage compared to the CT aspect, because CT aspect is very subjective. And we are able to do all the things which includes your assessment of the infarct, vessels, and even if perfusion required when you are doing an MR-based protocol. The only drawback of an MR-based protocol is time, because the patient is very uncooperative, is doing a lot, then we will not get a good quality image. But if I have to choose whether it is a CT or MR-based protocol, a good run-stroke program with a well-oiled workflow, MR-based protocol is always better. As MR is not available in most of the places, CT is an excellent option, because most of the trials have been done using CT as a imaging modality for stroke patient selection, provided that every patient with stroke undergoes both a plain CT followed by an angiogram and whenever required a perfusion for patient selection.
Yep. in resource poor situations in probably tier 2 or tier 3 cities where you don't have a luxury of even a CT angiogram. Sometimes what we always suggest our clinicians is if you identify a measurable neurological deficit and if CT is normal, CT brain development is healthy and BP is normal, they can comfortably thrombolize the patient and then refer to a higher center rather than wasting time in their center. This is very important because even to shift from one hospital to another hospital, which is just 5 kilometers away, in any city, traffic will take half an hour to 1 hour minimum. So that will waste a lot of time. So, and especially in tier 2 or tier 3 city, even to come to a nearest metro will take few hours. Probably for a mechanical thrombectomy, because the window is extended to 24 hours, anywhere across the state, you can do it. Suppose if a patient develops a stroke in 700 kilometers from Bangalore, okay, still they can be shifted. They can be thrombolized and shifted to Bangalore or in other states also because now the because of the 24-hour window, every patient who deserves a large vessel occlusion patient who deserves mechanical thrombectomy, we can access the care. Earlier days, it was because of just 1.5 hour extra additional window. There was a problem. Even if patient had resources, he still couldn't get the access to care. But now things are different. And CT versus MRI, this discussion, this debate is on and on. But if your center, if every neurologist in a hospital has to sit with his radiology team, has to sit with his emergency team, and he has to decide which is best suited for his workplace. And based on that, you can take a decision. So MRI, sometimes it may overestimate the infarct size. There are some complaints and comments that some clinicians get scared that it's already more than one third of MCA territory. So let's not thrombolize. It is not like that. If you identify acute infarct, if you identify there is a measurable focal or a global neurological deficit, probably you have to take a individual call on thrombolysis and then doing mechanical thrombectomy. So this is what we want to highlight in today's workshop. So if any other questions are there, any thing anybody wants to
There
add,
is
we have.
there is one
Yeah.
question. It is not very technical on board, but the doctor has requested is how do you manage consent delay in the hospital setup? Like how big of a factor is consent delay in terms of handling the patient and reducing the door to needle time matrix, and which specialty is usually the one who is mostly involved in the same?
See, there are many factors which act as barriers for thrombolysis. If you see a patient, because these are time sensitive treatment, acute stroke is always time sensitive. So, if you see commonly, what are the common barriers? One is lack of knowledge about the stroke care, the awareness, lack of awareness. Even now, we see a lot of our patients going to alternative forms of medicine I don't you want to use fake stroke centers. Probably they are like self-claimed stroke centers managed by not professionals. They are not trained professionals. Probably they use some kind of a orthodox care and practice. One most important thing is access to healthcare because of the traffic. Any city nowadays, the traffic congestion is too much. So this one reaching is difficult. But let me tell you, the consent delay is based on the treating team. We have thrombolized in this hospital more than probably 1,500. And if you see, only because of the cost concern, only hardly we had missed few. But it's our duty. As a treating doctor, it is my responsibility to talk to every responsible stakeholder of that patient. They may not be physically there. Son may be coming from Mumbai, but it's my duty or my, this one to call that person and say, boss, this is what is happening. Now the time is running out. This is the treatment which is internet. This is an international standard of care. This is not a research drug. This is not an experiment on a patient. You have to highlight that. Otherwise, he thinks that we are giving some drug as an experiment. It is not like that. This is a standard of care practiced across the globe. And if you confidently say, tell, and if you convince them, probably your consent delays will be minimized. I don't say it will not happen, but it's our duty to reduce it to the bare minimum time.
Sure, sir. I think that's it for the questions. There are no more questions, sir.
Okay. So then I thank Gennova team, Mr. Naveen, Mr. Kuti, Mr. Shiv, and all his colleagues, and Kalpita and team, event management team for hosting this national workshop. So probably we will have more such workshops or more such webinars coming up in coming months. What we will do is we'll highlight one case and probably we'll take it forward and we will have a collateral discussion on some of the I wouldn't say controversies, some of the gray areas in stroke care. So probably that's the idea of having these webinars. So thank you very much.
So thank you so much. Also, I'm happy to announce that we had around 170 logins for this session. So that's a very huge number to start off with. So thank you once again for all the time and for such interesting information about stroke. So I hope that together we can definitely make India more stroke aware and more stroke ready in terms of the hospital facilities. So thank you so much again for your time.
Yeah, thank you. I thank Dr. Kishore and Dr. Savit and Dr. Shruti for making their free time amidst their busy clinical schedule and joined us for this discussion. Thank you very much.
Next thing, we can stop with the recording. Thank you.